Evelyn was 67 years old and sharp her entire life. She taught high school biology for 3 decades, did the crossword every morning, remembered every birthday in her family without checking her phone. Then, one afternoon, she stopped mid-sentence at dinner because she couldn't find the word umbrella. A few weeks later, she missed her grandson's birthday entirely. She figured it was just aging. Her regular doctor checked her cholesterol, her thyroid, her blood sugar. Everything came back fine, nothing to worry about. When she came to see me, I pulled up her MRI. Her hippocampus, the brain's memory center, was measurably smaller than it should be for a woman her age. No tumor, no early Alzheimer's markers. What I found instead was a hormone her body had been quietly overproducing for years, doing damage so gradually that nothing in her standard labs ever flagged it. Most doctors aren't looking for it. And if you're over 60, this same thing could be happening to you right now without any warning. In the next few minutes, I'm going to show you exactly what it does to the aging brain, how to find out if it's happening to you, and what the research actually says you can do about it. Let me be clear about something first. This hormone is not the enemy. Your body makes it for good reasons. It wakes you up in the morning, helps you respond to a threat, manages inflammation. The problem isn't this hormone existing in your body. The problem is when it stays elevated for weeks, months, years, without ever coming back down to baseline. That's when it shifts from a survival tool into something that slowly dismantles the very structure of your memory. Here's what's happening at the cellular level. Your hippocampus, the region responsible for forming and retrieving memories, has an unusually high concentration of glucocorticoid receptors. Think of those receptors as docking stations specifically shaped to receive this chemical. Under normal conditions, this hormone docks briefly, does its job, and clears. But when this chemical is chronically elevated, those receptors are constantly occupied. The hippocampus responds by doing something called dendritic retraction. The branches of your neurons, the wiring that connects memory circuits, physically pull back. The connections don't just weaken, they disappear. Now here's where it gets harder to ignore. And this next part is what most people never get told, even by their doctors. The hippocampus has a second job that almost no one talks about. When it's healthy, it acts as a regulator, sending a signal back to the adrenal glands that says, "Enough of this chemical, stop producing." It's a feedback break. But once this hormone starts shrinking the hippocampus, that break weakens. So the adrenal glands keep producing. This chemical rises a little more. The hippocampus shrinks a little more. The break weakens further. It becomes a loop that feeds itself, and most people have no idea it's running. There's a second mechanism that doesn't get talked about enough, and this is where the damage accelerates. When this hormone is chronically elevated, it suppresses a protein called brain-derived neurotrophic factor, or BDNF. BDNF is the brain's maintenance crew. It grows new neurons, repairs damaged ones, strengthens synaptic connections. When this chemical runs high, BDNF production drops. The brain loses its ability to rebuild. Damage accumulates instead of getting repaired. This isn't theoretical. We can see it on scans. A 7-year longitudinal study followed 70 community-dwelling older adults with a mean age in their early 70s. Researchers measured baseline levels of this hormone at the start of the study, then imaged the participants' brains 7 years later. Higher baseline levels at the start of the study predicted smaller left hippocampal volume at follow-up. The participants with elevated levels of this chemical didn't just perform worse on memory tests. Their brains had physically changed. The atrophy correlated directly with the hormone level, not with age alone, not with other health variables, with this specific chemical messenger. When I looked back at Evelyn's history, the timeline made sense. This chemical had been elevated for years, running quietly in the background while she went about her life, while her doctors checked everything but this. Her hippocampus had been under a slow, steady chemical pressure the entire time. And by the time the word-finding lapses showed up at the dinner table, the structural damage was already visible on imaging. What I haven't told you yet is why this hormone stays elevated in people who aren't under any obvious stress. No crisis, no trauma, nothing they could point to. Now, you need to know what we're actually talking about. This hormone has a name. It's cortisol. And the triggers that keep cortisol high after 60 look almost nothing like what you'd expect. After 60, the body's cortisol recovery system slows down in a way that most standard medicine doesn't account for. A younger person hits a stressor, an argument, a bad night's sleep, a deadline, and their cortisol spikes, then drops back to baseline within a few hours. In an older body, that recovery takes much longer, days sometimes. So stressors that a 35-year-old body would shrug off in an afternoon can leave a 70-year-old's cortisol elevated for the rest of the week. The biology of aging changes the stakes of every stressor you encounter, even the minor ones. And that brings me to what I call the invisible stressor problem. Because most of my patients assume chronic cortisol elevation requires some kind of dramatic life event. A major loss, a serious illness, a crisis they can point to. But that's not what I see in the clinic. What I see is accumulation. Poor sleep stacked on top of social isolation, stacked on top of low-grade chronic pain, stacked on top of financial worry, stacked on top of having nowhere particular to be on a Tuesday. None of those things sounds catastrophic on its own. Together, they run the HPA axis like a leaking faucet that never fully closes. Sleep is a major piece of this, and it deserves its own moment. People with insomnia don't just feel bad the next day. They show measurable 24-hour elevations in both cortisol and ACTH, the hormone that signals the adrenal glands to produce more cortisol. Those elevations are highest in the evening and early night, which is exactly the window when cortisol should be at its lowest, when the hippocampus should be getting a break from glucocorticoid exposure. Fragmented sleep doesn't give the brain that recovery window. It keeps the pressure on through the night. There's another factor that almost never gets discussed, and I think it's one of the most important things to understand about cortisol after 60. It involves a hormone called DHEA. DHEA acts as a biological counterweight to cortisol. It doesn't eliminate cortisol's effects, but it moderates them, providing a kind of buffer for brain tissue exposed to chronic glucocorticoid pressure. In your 20s, DHEA is abundant. By age 70, it has dropped to roughly 20% of its peak levels. So an older brain isn't just dealing with cortisol, it's dealing with cortisol minus most of its natural defense against it. This means the cortisol-DHEA ratio shifts dramatically as you age, and that shift matters more than the raw cortisol number alone. A cortisol level that a 40-year-old brain handles without much trouble becomes genuinely damaging in a 70-year-old brain. Not because cortisol went up, but because the buffer went down at the same time. It's a double exposure, and standard labs don't measure this ratio. Most doctors never mention it. Robert was 71 when I first saw him. Retired engineer, healthy weight, no major medical history, no dramatic events in his recent past. His wife had needed hip surgery about 6 months earlier, and while she recovered, his sleep schedule fell apart. He was up at odd hours, less active than usual, spending more time alone in the house. No single thing he could identify as a serious stressor. Just a quiet 6 months of disrupted sleep, reduced movement, and reduced social contact. His morning blood cortisol, when his primary care doctor eventually checked it, came back within the normal range, so nothing was flagged. When I ran a full salivary cortisol panel on Robert instead, his evening readings were barely lower than his morning readings. That flat slope, where cortisol fails to drop off through the day, is a specific pattern that research links directly to hippocampal stress. His brain had been running under chemical pressure every night for months, and the only test that would have caught it was one that almost nobody orders routinely. And if Robert's story tells you anything, it's that the standard blood test wasn't built to catch this. The question is, what actually would? The test your doctor almost certainly ordered was a single morning blood draw. You get one number, one moment in time, and it gets compared against a reference range built around diagnosing adrenal disease, not brain aging. If your number falls anywhere inside that range, the lab report prints normal, your doctor moves on, and the conversation ends. The problem is, that test was never designed to catch what we're actually looking for. It measures total cortisol in your bloodstream, which means it captures all the cortisol bound to carrier proteins, as well as the free, unbound fraction. Most of what shows up in that blood draw is chemically inert. It's sitting on proteins, going nowhere, doing nothing to your brain tissue. The fraction that actually crosses into your hippocampus and binds to those glucocorticoid receptors is a much smaller slice, and a morning blood test has no way to separate the two. Salivary cortisol works differently. Saliva contains only the free, bioavailable form of the hormone, the active fraction that your brain is actually exposed to. That's the first reason it's more relevant for what we're trying to measure. The second reason is timing. A single blood draw gives you a photograph. Salivary testing gives you a film. You collect samples at 4 points across the day: waking, noon, evening, and bedtime. And what you get back is a curve that shows how cortisol rises and falls throughout a full cycle. That curve is where the real information lives. A healthy cortisol pattern peaks sharply right after waking, then drops steadily through the day, reaching its lowest point near bedtime. That falling slope is what gives the hippocampus its nightly recovery window. The hours when glucocorticoid pressure is minimal and the brain can do its repair work. When the slope flattens, when evening cortisol stays nearly as high as morning cortisol, that window closes. The hippocampus stays under chemical pressure through the night. That specific pattern, the flattened slope, is what multiple research cohorts have linked to accelerated hippocampal atrophy and worsening cognitive scores over time. Of all the numbers on that panel, the late-night reading is the one I look at first. It's the one that most clearly shows whether the hippocampus is getting a recovery window at all, or whether the pressure is running straight through the night. In controlled clinical studies, late-night salivary cortisol has shown roughly 92% sensitivity for detecting abnormal hypercortisolemia. That's a high-performing test for something most people have never been offered. And to put the numbers in context, morning serum cortisol runs approximately 22 times higher in concentration than morning salivary cortisol. They are not measuring the same thing. Treating them as equivalent would be like measuring the water pressure at a reservoir to figure out how much is coming out of your kitchen tap. What you want to ask your doctor for is a 4-point salivary cortisol panel: waking, noon, evening, and bedtime. You also want to ask specifically about the cortisol awakening response, the sharp spike that occurs in the first 30 minutes after you open your eyes. Both the slope across the day and the morning spike give meaningful clinical information that a single blood draw simply cannot provide. Evelyn's standard labs had come back unremarkable for years. Thyroid, glucose, CBC, all within range, nothing to act on. It wasn't until I ordered the salivary panel that the picture changed. Her evening reading sat at nearly 60% of her morning level. In a healthy pattern, evening cortisol should be closer to 10 to 20% of the morning peak. Her hippocampus had been absorbing that pressure every single night, and not one prior test had ever flagged it. So the real question isn't just what the damage looks like, it's whether any of it can be undone. Here's the question I get asked more than any other when this conversation reaches this point. Is the damage permanent? And the honest answer, based on the research we currently have, is no, not necessarily. Not if you act early enough. The most direct evidence comes from a condition called Cushing's disease, where a tumor causes the adrenal glands to flood the body with cortisol at levels far above anything stress alone would produce. Patients with Cushing's have, in effect, been running a controlled experiment in severe chronic hypercortisolemia. And what happens to their hippocampi is severe and measurable. But here's what matters for everyone watching this. When surgeons remove the tumor and cortisol levels normalize, the hippocampus grows back. A study of 22 Cushing's patients who underwent successful surgery found a mean increase in hippocampal formation volume of 3.2% within months of treatment. In some patients, it reached 10%. That is structural brain tissue recovering after the cortisol assault stopped. And the relationship wasn't coincidental. The correlation between how much cortisol dropped and how much hippocampal volume returned was strong, sitting at R equals negative 0.70. The more cortisol fell, the more volume came back. Direct, measurable, dose-dependent recovery. Now, Cushing's disease is an extreme case, and I want to be precise about what this evidence does and doesn't tell us. It doesn't prove that everyone with mildly elevated stress-related cortisol will recover the same percentage of volume. What it does establish is a biological principle. The hippocampus is not a static structure that simply erodes and stays eroded. It responds to its chemical environment. Remove the assault, and repair mechanisms engage. We understand part of why from the research on BDNF. When chronic cortisol drops, BDNF production recovers. Animal models show neurogenesis resuming in the dentate gyrus, dendritic branching returning, the cellular scaffolding that cortisol had been dismantling gradually rebuilding. The brain's repair machinery doesn't disappear under chronic stress. It gets suppressed. And suppression, unlike destruction, can be reversed. The data on non-Cushing's populations reinforces why acting on this matters. In a cohort of 304 patients with mild cognitive impairment, tracked over nearly 37 months, higher plasma cortisol predicted faster hippocampal atrophy over time, and patients with smaller hippocampal volume at baseline were more than twice as likely to progress to Alzheimer's disease compared to those who maintained volume. The hazard ratio was 2.15. But here's the part that actually changes what you should do with that information. Cortisol is modifiable. That's not true of your age. It's not true of your genetics. It is true of your cortisol. A modifiable driver of a modifiable risk is a target, not a sentence. The timing caveat matters here, and I won't soften it. The research is consistent on one point. The window for meaningful intervention is before structural damage becomes severe. There is a difference between a hippocampus under pressure that hasn't yet lost significant volume and one that has been shrinking for a decade unchecked. Earlier is substantially better. This is not a situation where waiting to see how things develop is a neutral choice. Robert's follow-up MRI, taken 14 months after he began working through the protocol I'll describe in the next sections, showed hippocampal volume that had stabilized. Not dramatic regrowth, but a halt in the trajectory that had been heading in one direction. His clinical dementia rating score improved. His wife told me he seemed sharper in conversations, less likely to lose the thread midway through a story. He described it as the mental fog lifting in stages rather than all at once. Those are the kinds of outcomes the biology predicts when the cortisol pressure is removed early enough and consistently enough. The evidence for recovery exists. The mechanism for recovery exists. And the first intervention I give patients isn't a prescription or a supplement. It's something they can start the same day they leave my office, and it works faster than almost anything else I recommend. Most interventions for cortisol reduction require weeks to show up in lab work. This one starts working the same day you try it, which is why I tell patients to start here before changing anything else. The mechanism is direct. When you breathe slowly, with an emphasis on a long, extended exhale, you activate the parasympathetic nervous system through the vagus nerve. That activation pulls a biological brake on the HPA axis. Cortisol production measurably drops within a single session. Here's what separates this from other stress management. A 2023 Stanford study tested 5 minutes of cyclic sighing against 20 to 30 minutes of mindfulness meditation over 30 days. The 5-minute breathing practice outperformed the longer meditation sessions on both anxiety reduction and positive affect. 5 minutes. That's the differentiator. A systematic review of 58 clinical trials confirmed it. Regulated breathing for at least 5 minutes per session, practiced consistently, produces significant cortisol reductions and measurable improvements in parasympathetic tone. The pattern matters. Slow, diaphragmatic, exhale dominant. Breathing at roughly 4 to 6 breaths per minute, where the exhale runs noticeably longer than the inhale. That specific rhythm shifts the autonomic nervous system toward the recovery state your hippocampus needs. The specific technique I recommend to patients is simple. 4 counts in through the nose, 6 to 8 counts out through the mouth. 5 minutes before bed. No equipment, no app, no cost. Sleep is the second piece, and the two work together. Sleep onset naturally suppresses cortisol secretion. It's one of the body's built-in mechanisms for giving the brain a nightly recovery window. But when sleep is fragmented or delayed, that suppression window either opens late or doesn't open fully. The hippocampus stays under glucocorticoid pressure well into the night, instead of getting the relief it needs. The evening cortisol spike is the specific target here, not the morning reading. Most people focus on their morning cortisol because that's what blood tests measure. But the damage to the hippocampus accumulates primarily during the hours when cortisol should be near its floor and isn't. Reducing that evening and nighttime exposure is where the nightly recovery window actually opens. Room temperature is a practical lever that gets overlooked. Sleep onset is tied to a drop in core body temperature, and an environment that supports that drop, typically between 65 and 68 degrees Fahrenheit, accelerates the transition into deeper sleep stages. Deeper sleep onset means the cortisol suppression window opens earlier and stays open longer. This isn't based on clinical trials specifically measuring cortisol against thermostat settings, but it connects directly to the established physiology of sleep onset and HPA suppression timing. The three-part implementation is this: 5 minutes of slow, exhale-dominant breathing before getting into bed, a bedroom kept around 65 to 68 degrees, and no screens for at least 30 minutes before sleep. Screen exposure delays sleep onset through light-mediated suppression of melatonin, which in turn delays the cortisol suppression window. All three of these changes work on the same target: getting the evening cortisol curve to drop further and faster. Breathing and sleep work on the rhythm, how high cortisol climbs and how long it stays elevated across a day. But there's a separate layer underneath that, one that determines how destructive the cortisol you do produce actually is at the cellular level. That layer is almost entirely controlled by what you eat. What you eat directly determines how aggressively cortisol acts on your brain tissue. It affects how sensitive your glucocorticoid receptors are, and that sensitivity is the difference between cortisol doing its job and cortisol doing damage. When you eat ultra-processed foods, foods cooked at high heat, charred meats, packaged convenience meals, your body accumulates compounds called advanced glycation end products, or AGEs. These generate oxidative stress inside your cells, and that oxidative stress interferes with the glucocorticoid receptor's ability to function properly. The receptor becomes resistant. Your body responds by producing more cortisol to compensate. So the processed food doesn't just raise cortisol through general inflammation, it directly drives a cycle where more and more cortisol is needed just to maintain basic physiological function. Quercetin blocks that resistance. In human studies, it neutralized the receptor resistance that AGEs would otherwise cause. It's in onions, apples, and capers. Adding raw onion to meals, choosing an apple over a packaged snack. These are targeting a specific biological pathway that's been documented in human cell research. BDNF, the repair protein that cortisol suppresses, has its own nutritional support system. Omega-3 fatty acids, particularly DHA from fatty fish, directly support BDNF production. This matters because cortisol and DHA are essentially working in opposition. Cortisol drives BDNF down, DHA helps bring it back up. Eating salmon, sardines, or mackerel 2 to 3 times per week produces a measurable shift in that balance. Not a dramatic one after a single meal, but a consistent dietary pattern over weeks changes the baseline. That's the level at which nutrition becomes a clinical intervention rather than general wellness advice. Blood sugar is another lever most people don't connect to brain cortisol. Every time blood glucose spikes sharply, the body releases cortisol as part of the metabolic response. A diet built around refined carbohydrates and sugary foods isn't just a metabolic problem, it's generating repeated cortisol pulses throughout the day, each one briefly exposing the hippocampus to glucocorticoid pressure. A diet that keeps blood sugar stable, whole grains, legumes, non-starchy vegetables, protein at each meal, reduces the total number of those daily cortisol pulses. It's a simple arithmetic reduction in hippocampal exposure. If you're already supplementing with vitamin D, and most of my patients over 60 are, I need you to understand this clearly because there's a specific dosing pattern that most people get wrong, and it can quietly undo the receptor work you're doing everywhere else. Short-term vitamin D appears to support glucocorticoid receptor function, but research on long-term, high-dose supplementation shows it can actually downregulate glucocorticoid receptor expression over time, which creates the same resistance problem as AGEs through a different route. The practical guidance here is to stay at standard dietary doses, around 600 to 1,000 IU daily from food sources like salmon, fortified dairy, and eggs, rather than pushing into the multi-thousand IU supplementation range without specific clinical indication. Magnesium is where I see the most consistent gap in patients over 60. Mild magnesium deficiency amplifies HPA axis reactivity, meaning the stress response fires harder and longer in a magnesium-depleted system. Most adults in this age group aren't getting enough from diet alone. Magnesium glycinate at 300 to 400 milligrams taken before bed works directly on blunting that evening cortisol response, the same window we targeted with breathing and sleep temperature. When I looked at Evelyn's dietary history after her diagnosis, the pattern was clear. Since her husband had passed 2 years earlier, she'd been living alone and relying heavily on packaged and convenience foods. Her omega-3 intake was minimal, her magnesium intake was low, and her daily diet was generating a high AGE load. That nutritional profile was actively making her cortisol problem worse, and none of her previous doctors had ever asked about it. Nutrition addresses the chemistry. But the hippocampus also responds to what your body does, not just what you eat. Movement and social connection work at the structural level, and that's where the real rebuilding happens. Diet works on the chemistry. Movement works on the structure. Exercise is the most potent BDNF stimulator available without a prescription. And the distinction between acute physical stress and chronic psychological stress matters here. Where psychological stress suppresses BDNF, physical exertion triggers it directly in the hippocampus. The same protein that cortisol has been grinding down gets produced in response to movement. You're not just burning calories, you're chemically counteracting the damage. The dose question matters more than most people realize. Low to moderate intensity exercise, practiced consistently, reduces baseline cortisol over time. But high-intensity sessions temporarily spike cortisol, which means pushing hard at the gym can work against the very goal we're trying to achieve. For anyone over 60 working on this specific problem, the target is 150 minutes per week of brisk walking, not interval training, not heavy resistance work, unless you're already conditioned to it. Enough exertion to raise your heart rate moderately, not enough to trigger a significant stress response. Where you walk also turns out to matter. Comparative trials putting forest walking against urban walking found greater parasympathetic activation and larger reductions in blood pressure in the forest condition. Not a small mood difference, a measurable physiological shift. The visual environment, the reduced noise, the natural light variability, something about that specific setting pulls the autonomic nervous system toward recovery in a way that a treadmill or a city sidewalk doesn't fully replicate. If you have access to a park, a trail, or any green space, that's where the walk should happen. Social connection is where I've seen the most resistance from patients, because it doesn't feel like medicine. But the evidence is direct. A 2016 study of 88 couples found that non-judgmental social presence shortened cortisol elevation windows after conflict. Not eliminated them, shortened them measurably. Supportive relationships act as a biological accelerant for cortisol recovery, compressing the time your brain spends under post-stress glucocorticoid pressure. The inverse matters just as much. Social withdrawal after retirement, after losing a spouse, after mobility becomes limited, creates a persistent, low-grade HPA activation that compounds quietly over years. Isolation isn't just an emotional state, it's a chronic physiological stressor with the same hippocampal consequences as any other unresolved cortisol trigger. The patients I've seen slide fastest are often the ones who became socially smaller without quite noticing it happening. For patients with mobility limitations, Tai Chi and gentle yoga both show consistent cortisol-reducing effects. A 2021 meta-analysis confirmed measurable stress score reductions from 12 Hatha yoga sessions, and seated variants are available for anyone who can't manage standing practice. The mechanism is the same as breathing. Sustained, gentle movement at low intensity shifts autonomic balance toward parasympathetic dominance. Robert joined a weekly walking group through his local community center about 6 weeks into his protocol. Within 3 months, his evening salivary cortisol readings had dropped enough to show a genuinely steeper slope across the day. He started sleeping through the night consistently for the first time since his wife's surgery. But his memory scores didn't fully stabilize until I reviewed his diet carefully and found something else. An ingredient he was eating regularly that was working against memory consolidation through a separate mechanism entirely. That's what I need to show you next, because what Robert found out applies to almost everyone. There's a specific ingredient, not sugar, not anything obvious, that a large portion of people over 60 are eating regularly, and it works against memory consolidation through a pathway that has nothing to do with cortisol. If you're doing everything right with your cortisol, but you're still eating this, you're still losing ground. Everything you just fixed can still be undermined by it. That's what the next video is about. It's on your screen right now. Click now, you don't want to miss this.